Good afternoon and welcome to our medical lecture series. I'm Dr. Galat Hakim, Assistant Vice President of International Healthcare Partnerships and Insurance Development at Baptist Health International. It is my pleasure to welcome all of you to this informative presentation. I would like to extend warm greetings to our friends across Latin America and the Caribbean and everyone joining us today. During this interactive presentation, you have the ability to ask questions via the Q&A feature located in the bottom of your screen. I will be the moderator for today's lecture. This afternoon, I have the distinct pleasure of introducing Dr. Marco Ruiz. His presentation is titled New Advances in the Care of Multiple Myeloma. Dr. Ruiz is a hematologist, oncologist, and clinical researcher and chief of HIV oncology and HIV stem cell transplantation at Baptist Health Miami Cancer Institute. He's a board certified in 6 specialties: hematology, medical oncology, internal medicine, geriatric medicine, hospice, and palliative medicine and infectious diseases. Dr. Ruiz received his medical training at the University of San Marcos School of Medicine in Lima, Peru. He also earned a Master's of Public Health from the Nuffield Center for International Health and Development at the University of Leeds in Sheffield, United Kingdom. His training included an internship and residency of internal medicine at San Juan City Hospital in Puerto Rico. He completed a fellowship training in hematology oncology at San Luis State Hospital in New Orleans, followed by an bone marrow transplantation at Ochsner Medical Center, also in New Orleans. Before joining the Division of Hematological Oncology and Stem Cell Transplantation at Miami Cancer Institute, Dr. Ruiz was an associate member of the Malignant Hematology and Cellular Therapy Bone Marrow Transplantation Program at Moffitt Cancer Center. He currently serves as a professor of medicine at Florida International University, Herbert Wertheim College of Medicine. Dr. Ruiz is an editorial board member for numerous scientific publications, is widely published in peer-reviewed medical journals, and delivers lectures at national and international venues throughout the world, of course. Please, let's give a warm welcome to Dr. Marco Ruiz. Dr. Ruiz, what a pleasure seeing you again. Thank you so much for accepting our invitation, and the floor is yours. You may begin.
Dr. Hakim, very nice introduction, and thank you for your kind words. I would like to just kind of express my gratitude to the Department of International Health Baptist Health System here in South Florida, Miami. And I would like to going to start by sharing my screen to start talking about this kind of a very interesting topic. At least is one of the interesting kind of developments in medicine over the last few years, which is the new advances in the care of patients with multiple myeloma. So this is the agenda for today. We're going to be briefly discussing myeloma. Basically, we're going to look into the basics of diagnosis, when we call it when do we call it MGUS or monoclonal gammopathy of unknown significance, what do we call it smoldering myeloma, and what do we call an active myeloma. We're going to briefly review about the optimal frontline therapies and the alternatives and options that we have these days. Also, we're going to briefly discuss about the cases for relapsed refractory myeloma. And something which is very unique and very exciting is we're going to discuss about the role of new treatment options or new therapies. And within this kind of therapies, we're going to look into the use of bispecific T-cell engagers and CAR T-cell therapy options for our patients. I'm going to start briefly with how to make a diagnosis of multiple myeloma, and I'd like to start with a case very quickly. I'm kind of presenting the case of a 60-year-old female patient who basically comes to your clinic for follow-up. She had a bone marrow biopsy about 1 year ago that showed that the patient had a monoclonal plasma cells in the bone marrow about in 10% of the cases, and 10% of cells. I'm kind of showing you the immunoglobulin profile. The patient, of course, has IgG kappa multiple myeloma. There is no CRAB criteria, and I'm going to refer you in the next couple of slides as to what I mean by CRAB criteria. And the question for us is, does this patient have monoclonal gammopathy of unknown significance versus smoldering myeloma versus active myeloma? they prompt us to, this slide is a perfect segue to start looking into how do we make a diagnosis of multiple myeloma. And this sort of a diagnosis has been it's been evolving and evolved over the last few years. The most recognized sort of definition of myeloma comes from the International Myeloma Working Group. And basically here we have, I present to you the sort of characteristics for MGUS, smoldering myeloma, and active myeloma. There are tiny little differences, and it's always important to recognize. For MGUS and smoldering myeloma, there is no end organ damage, which is present in the cases of active myeloma. And this is what I meant by the CRAB criteria that I showed you in the original on case number 1, in the first slide of case number 1. And this is basically specifically the diagnostic criteria. Over the last probably 5 or 6 years, new elements have been added to the classification of criteria. And now that we have something called a SLIM CRAB, which is basically the end organ damage definition of active myeloma. This is the way we define smoldering myeloma and MGUS. Interesting to note the differences between basically the amount of monoclonal plasma cells in the bone marrow, 10% versus more than 10%. In our initial case, of course, if we are about to classify this patient, as we discuss here, see that we don't have any CRAB criteria. The patient, of course, has IgG kappa disease. These are the immunoglobulin pattern. So likely this patient falls into the smoldering myeloma category. So what is important? What is the reason it's important to classify patients into something that we call MGUS versus smoldering myeloma versus active myeloma? The importance comes to the fact, indeed, the main point is that whenever a patient is diagnosed with MGUS or something we call monoclonal gammopathy of unknown significance, this is a test that is done in the blood. And basically, we're just going to do something called a protein electrophoresis in serum and also protein electrophoresis in urine. And then we detect whether there's an abnormal protein. This is important to know because there is certain specific criteria. And usually myeloma, in the majority of cases, not all of them, migrates from MGUS into smoldering myeloma and then finally into active myeloma. So the time frame from MGUS to active myeloma is roughly somewhere between 15 to 20 years. And for a smoldering myeloma into active myeloma, it kind of varies depending on certain specificities as we're going to review here. So the risk of the patient in patients who are diagnosed with monoclonal gammopathy or smoldering myeloma or active myeloma, it is important to know because it's going to give us an idea on how fast the disease will progress. And this is some of the algorithms that we use, basically to keep in mind that we take into account the amount of cells in the bone marrow. We take into account the ratio between the light chains that are affected. And we also just kind of take into account other parameters such as imaging studies. This brings us to the role of diagnostic imaging in multiple myeloma. Over the last probably 20 to 25 years, we didn't just kind of pay too much attention as to how to use some of these imaging studies. We tended to use more, we used to be more reactive when patients basically told us that they had some sort of a back pain or any other kind of issues, which is kind of that prompted imaging studies. But nowadays it's part of the original assessment of patients to just kind of perform something called a PET-CT scan, which is a standard of care, which basically is going to detect us whether there is some lesions in the spine, which belongs to this category or classification. As you can see here, MRI studies showing one or more focal lesion that is more than 5 millimeters in size. So as you can see, from a morphology-based disease that used to be worked up by the pathologist and the clinician 20 or 30 years ago, nowadays is more like sort of a cytogenetic molecular disease and also incorporating some of the imaging studies that are important. And now we have very good tools to be able to, we're able to predict the risk and we're able to predict how the myeloma, once it gets into an active stage, how it's going to evolve in a patient. That also kind of is correlated with the presence of certain specific biomarkers. And these are the biomarkers that we use, especially in the setting of having to make a difference between smoldering myelomas and active myeloma. As you can see here, we just kind of take into account some of the biomarkers, such as, for instance, the amount of the monoclonal gammopathy, or something that we call the amount of the M spike, the amount of bone marrow monoclonal plasma cells in the marrow, and the ratio between the affected and unaffected light chains. If you remember in the pathogenesis of myeloma, basically the plasma cells start to develop some ultra-immunoglobulins. That ultra-immunoglobulins at the end caused by specific translocations or certain specific mutations develop these abnormal proteins that as such cause the development of this abnormal protein that is found in the blood test under the name of a spike, and also just kind of develop this kind of a light change abnormalities that we observe also in the blood test. Once we know that we have three different phases, if you will, for myeloma, once we know that we have something called active multiple myeloma, so the next step before even we just kind of look into the possibility of looking into therapy options, we did start something called, we do look into something called the staging system. And as you can understand, patients with blood cancers is very difficult. And the classification or the staging is very different compared to patients who have solid malignancies. This is basically the ISS staging system, which is one of the systems that we use and the most used system for staging of patients with multiple myeloma. And you may wonder, why do we need to stage patients with multiple myeloma? The reason we do the staging is not necessarily to understand or to see where the disease is, but it's just kind of basically to assess two basic factors. Number one, overall survival, and number two, progression-free survival. When I talk progression-free survival means how long the patient is free of cancer and is still alive. And overall survival, the number of years that patients usually survive with the disease or when the disease is treated. As you can see here, fundamental differences. So here, whenever we have patients who are stage 1, you can see that the survival is better. Whenever we have patients with stage 3, you see in these curves, basically the survival is less compared to this curve and this curve. Important to know, because the higher your stage, the higher your risk, the less chances for survival. And that's also important in determining which therapy we're going to use. So following in case number 1, remember that we just kind of make a diagnosis of a smaller multiple myeloma. So this patient, of course, was doing okay until the hemoglobin dropped from 13 to 11, and the platelet count was 140,000. Just kind of stay about the same with a white cell count of 4.0, but there was a drop in the hemoglobin. We also, this patient presented to your office or your clinic with an LDH of 300. And then this patient, we're just going to do some studies in the bone marrow, and we just kind of show that this patient has something called a 414 translocation and a Gay1Q translocation. No CRAB criteria, according to the information given. The MRI of the whole spine was negative. Kappa and lambda chains were completely okay. The multiple myeloma cells or the monoclonal plasma cells in the bone marrow was 20%. And then the question is, are we dealing with a patient with an MGUS, MGUS, and we're dealing with a patient with smaller myeloma, or if this is a patient with active myeloma, what the stage would be? So of course, this is a perfect segue to just kind of review again. If we just kind of look into the characteristics of this patient, there is no CRAB criteria, right? So in other words, there's no evidence, but the patient has 20% or more. If you recall on a slide, on the first couple of slides, we need 10% or more of monoclonal plasma cells, plus the development of something else. In this case, it's anemia. There is no other reason for anemia for this patient. So this patient now has active myeloma. And then by looking into the characteristics of this translocation, so we're going to talk about this in the next few slides. So this patient has a 414, or again, Gay1Q means high-risk multiple myeloma, active multiple myeloma. So from a smaller myeloma, no treatment options needed. Now this patient went into active myeloma in which we need to treat the patient. One question that I always get from patients in regards to, because as you can imagine, we diagnose patients who have only just the abnormal protein, and we do have patients who have active myeloma and the ones in the middle. So the question that we always get is, why we don't treat patients who got just a normal protein or who have the smaller myeloma or the indolent myeloma or the dormant myeloma? The reason for that is because some patients who have the abnormal protein do not necessarily develop active myeloma at the end. And the time frame, as I told you, is roughly about 15 to 20 years. But some cases, some of the patients who have an abnormal protein, they never ever develop myeloma. So that is why we don't treat every single patient once we detect the protein. For patients who already transform into smaller myeloma, depends on the risk. There are certain characteristics that make patients high risk smaller myeloma. versus low-risk smoldering myeloma. The low-risk smoldering myeloma patients, likely they're not going to progress into active myeloma until probably about 5 years or so. The patients who are high risk, they're going to kind of have a good chance to transform or progress into active myeloma in the next 2 to 5 years. That is why now clinical trials are looking into treatment for smoldering myeloma patients who have high-risk disease. More to come in that regards. The standard of care these days is to treat patients only on active myeloma. Why? Because not every single abnormal protein progresses into active myeloma. So that is the reason. And of course, the time frame is 15 to 20 years. As you can imagine, if you live your life for 15 to 20 years with no medications, that means free of any significant side effects. And so far, the only clinical trials that we have documented the fact that we delay, if we treat patients with a smoldering myeloma, high risk, we delay the transformation into active myeloma. We don't stop the progression. Probably if we do an analogy with patients with breast cancer, if you take care of the lumpectomy via lumpectomy of a mass in the breast, the disease is gone. When you take also the same analogy with colon cancer, if you take the polyp or the adenoma out of the equation, the disease is gone. In the case of myeloma, the disease is progressing, but not everyone is going to progress into active myeloma. And as I said, the best clinical trials that we have are basically delaying, not necessarily stopping the natural course of the disease. So let's talk about the frontline therapy that we just kind of offer to our patients. This field has been experiencing revolution in terms of how to treat patients. This is basically the algorithm that we use to treat a patient with active myeloma. Remember, now we're talking about patients with active myeloma. So what we usually do is basically in patients, we divide it into two different groups. Patients who are eligible or good shape or good candidates for transplant, autologous transplant, and patients who are not candidates for autologous transplant. But you may wonder, why do we need to just kind of offer autologous transplant to every single patient? The answer is that until now, autologous transplant improves the time that you're going to be free of disease. It doesn't make any difference in terms of overall survival. But as you can imagine, multiple myeloma being more of a chronic illness, you're likely going to keep treating patients for a long period of time. So patients really appreciate when they are free of any interventions, or perhaps with minimal interventions, and they can continue with their lives. So that is why transplant is always offered to patients unless there are some contraindications. So the paradigm of treatment, usually we start with an induction therapy, which means immunotherapy, the word for our patients, consolidation, which means transplant, followed by maintenance therapy. In different parts of the world, there are different algorithms. In other parts of the world, they start with induction, which is shorter than the induction that we give here in the US, and then followed by consolidation, which is transplant, followed by more consolidation later, more treatment, followed by maintenance therapy. But just to give an idea as to what are the sort of the algorithm. And as you can see here, it is depicted how is the tumor burden, the amount of myeloma. As you can see with induction, it goes down, down, down. Then when you start transplant, it kind of gets much better. When you do maintenance, you maintain it here, but it doesn't necessarily goes completely away. So the word cure for multiple myeloma, unfortunately, is something that we're still are looking for in terms of treatment options. For patients with myeloma, they live more on a chronic disease pattern. We don't cure yet patients with multiple myeloma, but what we do is we put it under very good control. And as you can see here, with any alternative or any paradigm, the disease always comes back. And then it's just a matter of time, depending on the risk. If you have a low risk category, your disease is going to come back later. If you have a very high risk category, the disease is going to come back sooner than expected. So what are the best treatment options that we have for patients who are going to go for transplant? And the way we define transplant eligibility depends on the physical function of the patient, whether a patient has significant or certain comorbidities, and of course, whether the patient has significant sort of caregivers that are going to help this patient to go through the transplant process. And I would like to remind that the transplant process is basically nothing surgical, is more cellular therapy. So basically what we do is we do a lot of immunology when we're just going to talk about transplant. I'm going to talk about transplant in the next couple of minutes. So the same patient, now that he's been diagnosed, has an LDH of 450. LDH is one of the markers of activity of multiple myeloma. The higher, that means the more aggressive the myeloma is. With a beta-2 macroglobulin of 7, with 60% of cells of the monoclonal plasma cells in the bone marrow, and this is the amount of kappa light chains that the patient has. And of course, he asks you, what will be the recommendation at this point? So something that it is important to remember is that for transplant eligible patients, meaning that the patients who are really in good shape, either so far a 3-drug regimen or a 4-drug regimen are completely accepted as initial therapy. And within that context, it is highly recommended to start with an anti-CD38 immunotherapy agent. And the importance of this comes from these clinical trials, and I'm going to show you in the next couple of seconds. But so if there is a point to take home, is that patients who do a start therapy, they need at least 3 or 4 different drugs. And we're going to tell you what is the difference between one or the other. Usually within this 3 or 4, there's always should be an anti-CD38 agent. And this has been proven over the last couple of years, best prognosis, best responses, and patients do better. So 3 to 4 drug regimen is, of course, recommended, followed by autologous transplant. There is something called about that we're going to discuss in the next couple of seconds about maintenance after transplant. What is the role of post-consolidation post-transplant? The role of 2 transplants or one after another, and what is the main goal that we want to achieve with these treatments. A couple of years ago, I gave this lecture to another group, and basically the standard of care at that particular time was to do 3 drugs. Now it's 4 drugs for the very high risk or the ultra high risk multiple myeloma patients, and we're going to define those in the next couple of seconds. I'm going to show you briefly, very quickly, some of the clinical trials that basically ended up approving some of the medications that we know. This is the first clinical trial, the SOC S0777. In oncology, we present a lot of information in regards to clinical trials. So basically, groups are starting to work on a clinical trial, and then once the data is validated in a clinical trial, then it goes into the real world. So this is a first clinical trial showing the fact that indeed 3 drugs are much better than 2, and this is the curves. In the oncology literature, you're always going to see the design of the trial followed by the curves. And the curves usually are looking into something called PFS, or progression-free survival, versus overall survival. The time that you are free of disease, and the time that you are alive, and the total time that you survive. And as you can see, 3 drugs, BRD is basically the acronym for 3 drugs. Another thing also we do a lot in oncology, we tend to use many acronyms versus 2 drugs, RD. And basically this is Velcade, Revlimid, dexamethasone versus Revlimid, dexamethasone. Just going to show you that 3 drugs are much better than 2. And if you go back, this is basically almost 10 years ago when the clinical trial was studied and discovered that indeed 3 drugs are much better than 2. Same information done in a different setting. 3 drugs versus 3 drugs comparison, no major differences. So the reason they did this trial was to demonstrate indeed that whether perhaps the 3 drugs are much better than 2, but within the 3 drug regimens, we have perhaps a winner. The answer is no. All the options on 3 drugs and 4 drugs, for that matter, are very equivalent. It's very hard that we're going to see a head-to-head comparison between the 3 and 4 drugs categories. This is a Cassiopeia trial, very nice trial, looking to now the use of 4 drugs, as you can see, 1 plus 3, Velcade, thalidomide, dexamethasone, in newly diagnosed multiple myeloma patients. This is a trial that was developed a few years back and introduced the concept of 4 drugs for a specific population, especially the high-risk category. The Griffin study was a counterpart of that, the same thing. of the same approach. As you can see here, DVRD, 4-drug approach, as opposed to the 3-drug approach. So the 4-drug approach, better with more toxicities, but undoubtedly is going to be probably better for the high-risk category. 3 drugs probably should be okay, but no matter which one you choose, 3 or 4, usually an anti-CD38, and I'm going to show you, this is the anti-CD38 of election, daratumumab, the D here. Again, the same daratumumab plus another construct of 3 drugs, showing that indeed we have better responses with the 4 drugs and the 3 drugs, more toxicities, but better for the high-risk categories. So with the development of new drugs, and just to give you an idea, over the last probably 10 years, there's been about 10 to 15 new immunotherapy agents in the world of myeloma. And now I'm going to talk later about what is new in terms of myeloma. So once we have all of these kind of different elements, the question for us is, and as you can imagine, I didn't even mention chemotherapy. So for multiple myeloma patients, we no longer use chemotherapy. This is all immunotherapy agents. So which is, and all of this is delivered in the clinic, in the outpatient, in the cancer centers. Of course, we need to monitor the patient very carefully and so forth, but this is all delivered out of the hospital. Usually patients get into the hospital for complications, infections or other problems, progression of disease, when the disease returns and so forth. But all of this outpatient, which is amazing because now patients spend more time out of the hospital. Still, they use some time in the cancer centers, but it's still much better compared to what it used to be in the past. So with the development of these new strategies, the question that a few years back someone posed was, still we need bone marrow transplant. I told you that the autologous bone marrow transplant is a good option because it's very much needed, because it improves your progression-free survival, meaning the time of any medication and the time that you survive off medications, as opposed to it doesn't give you too much in terms of overall survival. Anyways, continue with the same case. You treated the patient with your regimen of election, and the patient achieved a negative MRD and a stringent CR, meaning the best response after 6 cycles of therapy. And of course, the patient asks you, shall I need to get a transplant or not? So far, and this is still the standard of care, the patients, usually if there's no contraindications for transplant, all the patients with myeloma should go for autologous transplant. Remember, transplant is not the end of the pathway. It's just one therapy that consolidates, if you will, reset the bone marrow. So then what we do on autologous transplant, we get cells, stem cells. We administer certain medications to the same patient. We release the stem cells from the bone marrow, and the stem cells are collected peripherally via catheter. We have a special machine in which we collect those stem cells, and then we prepare the patient for autologous transplant. What does it mean, autologous transplant? We're just going to give him one medication called a conditioning regimen called melphalan. That used to be an old drug in the old times of myeloma. The melphalan makes a space for the cells that were collected from the patient, and then you return these patient cells after you give it the melphalan or the conditioning regimen. Believe it or not, this is given as an outpatient. We don't have to admit this patient to the hospital. It's given 1 day of treatment, 1 day of rest. We return the cells to the patient, and we watch the patient very carefully. Of course, we watch for complications. What are those complications? Infections. We check until the bone marrow starts working, which is roughly about 14 days after the transplant. So we support this patient, support the patient by giving them transfusions, by giving them blood transfusions, platelet transfusions, and so forth. So still, there is a role for transplant. This is a clinical trial, believe it or not, 15 years ago, looking into trying to respond to that question, whether the transplant is still needed, and indeed it improves something that we call progression-free survival, not overall survival. And then it was delivered with maintenance therapy that we have here that we're going to talk in the next couple of seconds. So as you can see here, folks or patients who went for the treatment plus transplant, this is the curve, versus the patients who only got treatment, no transplant. As you can see, more time free of disease, more time, the survival, not much difference. But this is important if you're dealing with a patient who has chronic illness, meaning that we need to give these patients for a long time medications. Of course, this is very important. This is another study called Stamina, simple thing, basically now comparing 1 versus 2 transplants. The 2 transplants are called tandem transplants. Basically, they are given an offer to patients who have a very high risk category. In the US, it's only certain centers. We still use the tandem transplants, especially for the very high risk population, for something that we call the extramedullary disease, or extramedullary patients have extramedullary disease, myeloma extramedullary disease, and we offer the tandem transplant. A recent trial, I think is a Canadian trial, have shown that there's no major differences. In Europe, they tend to use more of the tandem transplants. Here in the US, it's sort of depending on where you go or specific areas. But it helps, especially only for the high-risk population. So transplant per se, much better than in terms of offering you time with no interventions or time of therapy. And as you can see here, highly debatable. Looking to the tandem transplant, meaning 2 transplants versus none versus 1, and the overall survival, there's no major difference. So with these trials, the question was, okay, so we did induction therapy, we did the consolidation under the format of a transplant, so shall we just gonna give some maintenance therapy to these patients, knowing that still there's gonna be some residual cells even after transplant? And of course, I'm gonna continue with the case. The patient underwent transplant. He had an autologous transplant. This is a conditional regimen, no major significant issues like the majority of patients do, no issues. And at day 100, the patient had an MRD negative bone marrow, meaning there was no evidence of minimal residual disease. And then the question is what to do at this point. Now, this is highly debatable for now, and it's still not approved. We'll start patients on maintenance therapy. The maintenance therapy came from this clinical trial that was developed in the year 2017, looking into maintenance therapy with one drug called lenalidomide after transplant. And as you can see here, look at the differences in terms of overall survival. Here, patients who got control, meaning no lenalidomide, versus the one who got lenalidomide. Difference is 62% versus 50% in terms of overall survival, significant difference. So that is why this trial prompted the start of maintenance therapy after transplant. More studies, and basically there was a significant sort of, if you will, analysis as to what to do based upon risk categorization. And of course, all of them were in favor of maintenance therapy. But of course, the question was, which maintenance therapy? Lenalidomide was the medication that was the winner, and this is basically given for the low and the standard risk patients after transplant as a maintenance therapy. And of course, there is initially in the original trials, there were some issues related to the fact that some of these patients didn't respond very well to, especially the high-risk category, didn't respond very well to the lenalidomide. So that's why another group in Europe started to look into the use of bortezomib, which is a proteasome inhibitor administered subcutaneously. And I showed that bortezomib gave a better option for the high-risk category. So far that we know is lenalidomide for the low and intermediate risk maintenance therapy after transplant. And also, if you don't do the transplant, also you finish a certain amount of therapy, usually 12 months, and assess the patient for maintenance therapy. And for the high-risk category, you do the bortezomib. Again, looking into the difference in terms of survival for the high-risk category. The Tourmaline, another study looking into the use not only maintenance therapy with other two, but another drug called ixazomib, which is another proteasome inhibitor, roughly indicating that indeed there is a significant difference. And of course, when you see here, progression-free survival and overall survival. So up to 4 drugs now are approved for maintenance therapy, and the maintenance therapy is chosen based on risk categorization. So we'll talk about transplant patients, so what to do with patients who are not really eligible for transplant. For instance, patients get diagnosed with myeloma at the age of 75 or above, patients who have some comorbidities, medical problems and so forth. So we're going to present now case number 2, which is an 85-year-old patient diagnosed with myeloma, active myeloma. with these translocations, who has a good physical condition, very active life, 85 years old, female, no major comorbidities. And what are the treatment options for this patient? Looking into some of the studies, looking into the use of 2 versus 3 drugs for elderly and semi-frail or frail patients. Again, 3 drugs are better than only 2 drugs, as we saw in the more fit patients. But again, wanted to show you the curves that truly impacted and made a difference in terms of looking into the option of a 3-drug therapy as opposed to 2 drugs. Up to probably the year 2000, there was only some kind of election of 2 drugs for elderly individuals. But then with these trials, that was completely eliminated. And patients who are fit, regardless of the age, of course, we need to be very careful. We start also with 3 drugs. Again, looking into the differences and some of these trials looking into the effectiveness of 3 drugs in elderly population. We use something that we call the VRD Lite, which was sort of a preferred regimen in many clinical trials, or also in many settings, that show indeed that there's a significant improvement in progression-free survival and overall survival compared to the 2-drug option before the start of the clinical trials. The MAIA study, again, looking into the use of the anti-CD38, and I told you that regardless of whether a patient chooses 3 or 4 drugs, and regardless if a patient is fit or unfit, of course, depending on circumstances, the anti-CD38 daratumumab should be used because that helps and improves, control the disease very quickly, and also improve progression-free survival and overall survival. This is the design of the MAIA trial. As you can see, here the improvements compared to the use of daratumumab versus no daratumumab in this arm. The ALCYONE trial, quadruplets in elderly patients, just kind of show, of course, significant difference. But of course, we need to be very cautious about using 4 drugs in very elderly patients. What do we mean by very elderly? Likely 75 and above years old patients. And as you can imagine, and you probably know, many of our patients are over the age of 70 or 75. So in certain circumstances, but you need to be very careful in the selection, you could use 4 drugs as opposed to do 3 in elderly patients. That have shown that improve progression-free survival and overall survival dramatically. So to recap, for frail elderly patients, 3 drugs can be used, provided that we don't have or significant issues with the patient. There are certain specific regimens that are used, especially when we're facing renal dysfunction. Usually, the combination of these regimens can be used. When there is cardiac dysfunction, avoid this drug called carfilzomib. And also, I'm just kind of showing you what to do in the cases of peripheral neuropathy, aggressive high-risk disease, and extramedullary disease. Sometimes we have patients who have very aggressive extramedullary disease or secondary plasma cell leukemia, in which we have to use chemotherapy interventions. Those are usually given in the hospital. And immunotherapy sometimes will not be sufficient for those patients. So this is a summary as to how we treat patients who are transplant eligible versus the ineligible. Just wanted to show you some of the different options. And let's briefly talk for a minute or so about minimal residual disease. I think I show you in the cases that we have patients, and I mentioned about minimal residual disease. We have a 71-year-old gentleman who basically is a standard risk disease. They have a negative MRD, a stringent CR before autologous transplant, received quadruple therapy, 71 years old, and the transplant with no issues. The PET-CT scan and the MRI were negative after day 100. The patient has a morphologic CR while awaiting MRD status. How will change your approach? I wanted to show that MRD has changed the world of myeloma. About 4 months ago, the FDA approved MRD as an endpoint for clinical trials. It's very important now because many drugs are going to be or have a very expedited review and approval. Before MRD, there was a lot of confusion because MRD means that you do your specific tests and you look for one cell in 100,000. So if it's MRD negative, you can see there is very detailed this, as opposed to the parameters that we used to use, complete remission, very good partial response, partial response. It was so confusing. But folks in the world, we are in the world of myeloma, we were so happy 4 months ago, the FDA approved MRD as an endpoint. So in other words, all the drugs coming up or being up that will be approved by the FDA from now onwards are going to use the MRD endpoint. So in other words, the drugs are going to be approved based upon the MRD, and MRD is going to be one of the factors that are going to be taken into account for clinical trials. So whenever you have MRD positive, of course, you may want to perhaps give them a bit of more extra therapy. Whenever you have MRD negative, now we're kind of thinking about the possibility of even discontinuing maintenance therapy. We'll talk about that. This is the basics of the trials for the MRD and these types of MRD. We have two types of minimal residual disease evaluation, flow cytometry and next generation sequencing. The two have different sequences, but it's important to mention because now we're using MRD in regular practice, and it's important because now we are getting into other technical questions that we're going to refer in the next couple of seconds. And this is the way we use MRD in the clinic today, and we're going to talk about these potential scenarios. Atopic myeloma is not complete if we don't talk about supportive care. Supportive care for myeloma is important. In this case, we have a 58-year-old gentleman who comes status post-transplant, who is doing great. The workup at day 100 show negative MRD. Patient is on maintenance therapy, and the patient asks about bone protection. And of course, you respond, what is the standard of care for these patients? That brings us to the discussion on the use of bisphosphonates. Bisphosphonates are important in the treatment of multiple myeloma, active multiple myeloma patients. It is important because we have two different products available, palmitoyl and zoledronic acid. Traditionally, it should be, any of them can be used up to 24 months in total, even pre and post-transplant, for bone protection purposes for patients with active myeloma. So that is an important supportive issue that sometimes we tend to forget. Immunosuppression happens in patients, of course, who get exposed to treatment or immunotherapy. So it's important to cover and avoid infections in our patients. Usually what we do is we protect patients against reactivations of VZV, which is varicella zoster virus, or HSV, and we usually start patients on a cyclovir prophylaxis. And in some occasions, depending on the patient, who are neutropenic, we give in something to protect them as well, antibiotics and also antifungals. And in patients who receive a certain amount of steroids, meaning more than 20 milligrams of steroids a week, we start looking into the use of PJP prophylaxis, or pneumocystis jirovecii prophylaxis. Vaccinations are important. Remember, once we transplant a patient, the immune system returns in about 6 months or so because it's an autologous transplant. And we deliver and we have a specific calendar for vaccinations for our patients. So we talk about initial frontal therapy or upfront therapy for transplant eligible, and let's talk briefly about refractory disease. I told you that the majority of patients, and almost all patients, return or the myeloma returns. So we have a 59-year-old gentleman who has a multiple myeloma high risk, transplanted and relapse after 2 months after transplant. Lines of therapy, this is what he used, and the patient received chemotherapy ×3 with a stable disease. And the next step in therapy of this patient, and let's talk about this. Let's talk about what would be the next step of therapy. So this is basically basically to show you when and how we categorize patients who are relapsed refractory. This is the criteria. Basically, at any point, whenever you see an increase on the abnormal protein in the blood, or when you see an increase in the light kappa chains, or when you see a decrease in the hemoglobin or worsening of renal function and so forth, so we need to suspect relapse disease. Relapse disease is not good at all because survival usually and progression-free survival decreases dramatically. So we have some alternatives. And of course, we have many different options. And usually what we do is looking into always try to replace 2 drugs. Remember I told you it's either 3 or 4. So out of the 3 or 4 regimens, usually try to replace 2 new drugs for 2 new members of the same or different families. So then we can successfully treat relapse disease. Some of the algorithms that we use, I presented you here. As I said, we have so many different options that it's good to start looking into which one of those we're going to use. And this is just the perfect segue to introduce CAR T-cell therapy. I told you that we review sort of the upfront therapy for transplant eligible and ineligible. We review very briefly about relapsed refractory disease. And also within that sort of dimension, we are in the relapsed refractory disease. We're going to just kind of talk about CAR T-cell therapy. CAR T-cell therapy and bispecific T-cell engagers is basically the newest in myeloma treatment. Over the last probably 2 or 3 years, there's been a development of CAR T-cell therapy products and also of bispecific T-cell engagers. But what is CAR T? CAR T basically is a lymphocyte. The way we do it is a lymphocyte or lymphocytes that we extract from the patient, and we call that leukapheresis. We extract some of the lymphocytes. We send it to a lab, bioengineer those lymphocytes, and we choose a specific target within the myeloma cell. And the target that is chosen in the majority of cases is called the BCMA. B, Brian, C, Charlie, M, Mark, A, Anthony. And the BCMA target is basically very well expressed in myeloma cells, in all myeloma cells. And it's different because it's not expressed in other specific normal cells, if you will. So this is the way CAR T-cell therapy has evolved over the last close to 7-8 years. As you can imagine, in 2017, it was the first approval. And CAR T-cell therapy is not only used in myeloma patients, but also in lymphoma patients and acute lymphocytic leukemia patients as well. And as you can see, this is the sort of the timeline. And this is the last product. This is basically myeloma product. And this is myeloma product. The 2 latest developments are basically for myeloma patients, Abecma or the ide-cel and the cilta-cel. And as you can see, very recent, 2 or 3 years down the road. These are the indications, and this is for patients with lymphoma. And if we go, this is the indication so far for the myeloma products. Usually in the 5th line of therapy, meaning whenever you use all your immunotherapy combinations, and even including transplant, you may want to use these CAR T-cell therapy products. This is the recommendation. And I'm going to show you in a future slide as to what other groups of investigation or research are doing to try to upgrade it, meaning introduce it soon or sooner in myeloma patients. This is the clinical trial, the KarMMa trial that got the approval of ide-cel. And as you can see here, it shows significant difference in overall survival compared to patients. Remember, the majority of these patients are patients who fail to almost all therapies. Very nice, very interesting, very unique, very novel. And basically, patients who were included on these trials failed all of this. As you can imagine, very difficult. Patients triple or quadruple or pentuple refractory, which means really bad news. But then with the CAR T-cell therapy, we have a new opportunity for patients. This is the constructs, some of the constructs. Construct means how we develop the CAR Ts. Usually we need to look for 2 different antigens, one that anchors into the myeloma cell and the other one who does the effect and attack the cell. And this corresponds to include getting the immune system or more attacking those specific cells. As you can imagine, we administer a certain amount of cells, usually about 450 million cells in a patient per ml. And then when that happens, the cells expand. So CAR T-cell therapy expand and maintain the sort of the control of myeloma. The responses are being outstanding. And so far, the experience has been great, but unfortunately, some of these patients still relapse. So more information is coming in regards to what is the effectiveness of CAR T-cell therapy. But as you can imagine, 5 years ago, we didn't even have this option. And we had to treat patients with very unique treatments, many of them perhaps a bit ineffective. And then unfortunately, patients didn't respond very well. So nowadays, we have a much better option. This is just to also, but of course, this comes with a specific price. And these are the prices for some of the CAR T-cell therapy products. Once we do more, the prices are going to go down. Once we start looking into and do better, strategies, of course, the price is going to come down. And finally, we just kind of talk about another new development, which is the bispecific T-cell engagers in multiple myeloma. I'm kind of offering you bispecific T-cell engagers. Basically, there is a group of products that are being developed against the same target, the BCMA. And basically what it does is basically is a specific, is an antibody has two different, if you will, receptors. One of them, the same principle of a CAR T attaches, and the other one calls the immune complement or the complement system to attack the cell. So it's a specific anti the BCMA, which is one of the antigen that is expressed in myeloma cells. And these are some of the products that we use. We use teclistamab, we use elaratamab, we use talquetamab. These two are still in progress, and the responses are being dramatically amazing. The responses are as good as a CAR T-cell therapy. Remember, it's the same product, the same target, kind of similar product. The responses are very, very, very nice. It gives us another chance and another opportunity for many of our patients, especially the ones who were refractory. If you think very carefully, many myeloma patients are going to relapse. And with the relapse, their risk gets upgraded. And when that happens, the medications that we have so far are less effective. So that is why CAR Ts and the bispecific T-cell engagers are a novelty and are very nice in the armamentarium of myeloma treatment. But of course, it also has some side effects, and these are the side effects: bacterial infections, bacterial reactivations, something that we need to be very careful about and we monitor constantly in our patients. For the approvals of the ide-cel and the cilta-cel multiple myeloma, as you can see here, the majority of these patients have multiple lines of therapy, all the products that I showed you before. And of course, unfortunately, as we refer, there's always some mechanism for resistance. But also now we have better options, but of course, some questions. How are we going to do? Are we going to do first are we going to do first CAR T-cell therapy? Are we going to do bispecifics first or vice versa? Nobody knows that. What we know is that because the two attack the same receptor, it's going to be very important to perhaps do CAR T-cell therapy first, and upon relapse, use your bispecific agents. This is what we have. And finally, in conclusion, we have, of course, we just kind of review about, we make a sort of a rapid review of the definition of myeloma, the risk stratification, how we're going to treat patients on the frontline therapy, how we're going to treat patients on relapse refractory disease. And I just kind of I presented the information about the CAR T-cell therapy and BiTEs, bispecific T-cell engagers, truly novel strategies for the treatment of relapse refractory and multiple myeloma patients. And with that, if you have any questions, more than happy to respond. Thank you very much for your time and your attention. Thank you.
Thank you, Dr. Ruiz. Wow, this is incredible what you guys have accomplished in regards to multiple myeloma, not counting with the myriad of treatments that you actually also use transplants for. And I'm just curious. I know the numbers from prior years. Where are you now? How many transplants have we conducted at MCI currently?
In the cancer center, we probably have more than 350 transplants so far.
Already.
Yes, already. And with CAR T-cell therapy products in clinical trials, I think we've done 10 plus 20 to 30 this year so far. For the bispecific T-cell engagers, we have about, if I recall correctly, 40 patients already. So as you can see, more and more is coming. So if you add the 350 plus the 40 plus the 40, so in general terms is kind of a very busy, of course, very busy landscape for us, but very promising and very exciting because of the new options of therapy that we have for our patients.
Indeed. One thing that it always comes to mind when we hear a new diagnosis of multiple myeloma is obviously, am I going to survive this? And obviously in cancer, we always talk about the 5-year survival rate for any treatment. And I recall not long ago when I was reading in the American Cancer Society website in regards to the survival rate for multiple myeloma post allogenic treatment, and it was about 57% survival rate. Is that still an accurate number?
It's still, but it's going up. It's even higher.
Still,
yeah.
Oh, fantastic. Wow.
It's probably more than that, 60 to 65, depending on the risk. For all
Uh,
newcomers, probably is in the range of 60 to 65 at least. And based upon the new regimens, of course, because one thing is overall survival, another thing is progression-free survival. So
exactly.
the time free of any intervention.
Correct. And you did brilliantly mention and made it a point to actually make sure we all understood that there is no cure for multiple myeloma. So in
So far,
essence,
so far, but it will be. It will be.
it will be, God willing, if we keep individuals and scientists such as yourself focused, we definitely will get to that. Talk to us about that particular willingness to get to a point in which you say, you know what, we are going to hit that mark, and where we can say that perhaps we can actually win the battle against multiple myeloma. What is it that you're lacking at this point that is not getting you to that level?
I think what is happening in the field of myeloma, and thank you for the question, is that over the last probably 20 to 25 years, we use for our clinical trials and approvals, I guess, measures or endpoints that were really perhaps outdated. Nowadays, with the MRD, MRD means that you don't find the disease based upon the latest instruments that you have. And now, when I talk about MRD, is like MRD is 10 to the minus 5 or 10 to the minus 6. So now the idea is to do MRD 10 to the minus 6. Can you imagine? 10 to the minus 6 means one cell in 1 million cells. So
Wow.
you can identify 1 in 1 million cells. And I think that is now going to be the standard of care. So how that's going to change the landscape of research and clinical trials is that because everyone is going to be looking for MRD.
Mm-hmm.
What does it mean? That means that perhaps if a patient is MRD negative, we can stop maintenance therapy. And if we stop maintenance therapy, we can observe the patient. And if the patients don't relapse, that means that they're cured. So that's where the word cure, after 30 years in the myeloma world, start to just kind of get into the ground up now, discussing about possibility of cure. So far, nothing, but with the MRD sort of a assessment, things are definitely going to change for the good for the field, and very likely we're going to have more and more of these trials looking truly for MRD. And with time, the MRD is going to be from 10 to the minus 5 to 10 to the minus 6 to 10 to the minus 7 to 10 to the minus
Wow.
8. So you can imagine, 1 cell in 100 million cells, that is basically no disease. So in other words, that is what we're going to be able to tell cure. And then likely we're going to stop maintenance therapy strategies. Nowadays, we stop it at year number 2 if the patient is MRD negative after transplant or when finished 1 year of treatment. And then now we can tell the patients with certainty, we stop it, nothing is going to happen. And we're going to follow you.
That is remarkable. And in your opinion, how far are we from reaching that stage?
I don't think it's going to be so far. I think it's probably going to be in the next probably 5 to 10 years.
Wow.
This FDA approval significantly just kind of propels the field into levels that never existed. Now we can talk seriously about eradicating the disease.
That is absolutely remarkable. And of course, I'm sure that it's always in the back of your mind every time you do an allotransplant, the fact that although we know that the allotransplant reduces completely those risks, that we actually see from the graft versus host disease and in the allotransplant. I'm sorry. Now doing the autologous obviously gives you some kind of a peace of mind. However, there is still that risk that the condition might recur. How often does this occur in your practice? How often do we see recurrence of multiple myeloma? What is the percentage of risk?
Usually about 50% at least of patients after transplant may relapse. The projection is after CAR T cell therapy, close to 50% will relapse. Others may get cured. We don't know that yet because we're doing the MRD status, and we never did that before. So now we're just kind of using that algorithm. And usually for myeloma, it's autologous transplants, usually the ones that we use.
Wow, that is phenomenal. And then the incredible thing is that you have in your armamentarium not only the fact that you can actually do the autologous transplants, but you can also select later on CAR T cell and immunotherapy and customized care for your patient. And some of the medical students and some of the peer internists that are currently logged on might think, darn it, I wish we can actually prevent these conditions from occurring, but sometimes it is somewhat of an incidental type finding because the symptomatology blends into other conditions per se. So, to identify that proactively perhaps is one of the biggest conundrums that you as a hematologist and oncologist might be confronting. Doctor, there is a question from Jose Chacon. It says, he says, great presentation. Would these three drug regimens apply to those with Wallstrom?
Oh, I think he's referring to Waldenstrom disease or Waldenstrom macroglobulinemia. I think with the this is what the way I think with Waldenstrom macroglobulinemia, I think there is an intense debate as to one day in regards to and again, I'm not a lymphoma guy, but the discussion is as to whether use one or two or three drugs. So far that we have BTK inhibitors approved for the use of Waldenstrom, which is basically called is more like an indolent lymphoma. But I think potentially that could be used in that regards. The issue is always what is going to be the end goal of Waldenstrom. Waldenstrom is basically more an indolent lymphoma. Hardly ever treat these patients unless there is a need to treat pancytopenia, so when the patient has developed some symptoms, so the patient is symptomatic and so forth. But again, the BTKIs have changed the landscape of Waldenstrom disease. And I think that's probably more to come. And I think it's more to expect from also the development in many different subfields of malignant hematology.
I believe that during my introduction, I did highlight the fact that you are one of our HIV specialists, and rightfully so, I must re-mention that. What is new in the HIV treatment? I know we're talking about multiple myeloma, but I know you're very passionate about using some of the treatments, innovative treatments for HIV. Can you share with us what is going on at MCI?
Sure, absolutely. Thank you for the question. So in regards to HIV treatments, we are part of the AIDS Malignancy Consortium, so we just kind of have a different set of clinical trials. The HIV, we do have indeed a patient in who we transplanted about probably 4 or 5 years ago, if I recall correctly, who is cured of lymphoma and cured of HIV. But of course, that was because the patient had plasmablastic lymphoma. Patient is doing great these days. We stopped the antiretroviral therapy 2.5 years ago, and is still undetected with CD4 counts in the thousands. So he's doing and things. And as good news is the lymphoma never came back, because plasmablastic lymphoma is very aggressive. So in terms of HIV, there's new developments, I guess, in terms of treatment options and therapeutics for HIV oncology patients. We're trying to simplify because some of these, for instance, if we had a patient with HIV and myeloma, we would have treated the same. We would have offered a transplant and so forth. For other areas, I think it's some of the HIV infected patients may not necessarily be included in clinical trials. Still, we use chemotherapy for them, but that is improving. In other words, for HIV cancer patients, they are much more included now in the clinical trials. In the HIV world, I think there are new drugs that are given every 6 months or once a year, which is fantastic because patients don't have to necessarily just kind of go and get, the side effects related to the daily combos. But other than that, I think it's a significant progress. There is a lot of research going into also complications associated with hard therapy or antiretroviral therapy. But again, all the fields are kind of at this point kind of making progress in terms of new discoveries.
That is remarkable. One last question, Doctor, and
Sure.
this comes from Andres Guerra, and he says, Dr. Ruiz, excellent presentation. In some Latin American countries, certain mature drugs such as melphalan oral dosage are considered. Is it still recommended as a therapeutic option in patients with multiple myeloma?
That is a great question. Thank you for the question. I think it's, again, In the field of myeloma, you basically have to work with what is available to you. And melphalan low dose is used in some countries. And remember, we are very lucky here in the US and other countries and perhaps in Europe because we have the availability. And here in the US is basically a luxury. We have the availability of all different drugs, but in other contexts, when there is no availability, low dose melphalan is indicated and is being used for many years and is still used. This reminds me of the story of thalidomide in Europe. Remember thalidomide, it was until probably 4 or 5 years ago, the Europeans in all the clinical trials, and I show you some data from the Europeans, the VTD regimen, they used thalidomide, something that we have not used in the US, but that doesn't mean that it's wrong. That's what they had. And with the approval of lenalidomide and pomalidomide, now they don't use thalidomide much. But up to probably a few years back, they continued to report on thalidomide. So for melphalan oral dose, of course, if there is the only option, of course, there is the only way to do it, and still do it. And I think that's, again, the guidelines, if you have availability of different immunotherapy elements, of course you can choose, but there is not many. You have to use whatever is available to you, and there's nothing wrong with it.
Absolutely. I think that is a phenomenal point. Dr. Ruiz, you know what? We always enjoy your presentations, your scientific approach to all these incredibly complex conditions are absolutely amazing. And we are so, so grateful for you and for your talents. And we are so proud to have you in our team. I would let you go this time. And I want to thank you on behalf of our international team for your incredible presentation and for your incredible personality. We always enjoy having you in these conferences. And to all of you for participating today, thank you so much for your questions and for always being so attentive to our seminars. If you have additional questions or if you have any doubts, or you have a concern about one of your patients, please send them to us at bhiwebinars@baptisthealth.net. We will make sure to send them to Dr. Marco Ruiz for him to elaborate and we can discuss further. And of course, we look forward to seeing you at our next medical lecture series, which is scheduled for November 13, 2024. Have a phenomenal start to your semesters, to those medical students joining us today. And to everybody, thank you once again, and we'll see you soon. Dr. Ruiz, thank you.
Thank you very much, as always. Thank you for the invite. Thank you much. Have a good day.
You too.